Hello, we're Team Care. We're working on preventing hospital readmissions for diabetic patients. The Centers for Medicare and Medicaid Services, also known as CMS, defines a readmission as an admission of a person to a hospital within 30 days of a discharge from that hospital or from another hospital. Readmissions commonly cause stress and hardship for patients and families. Additionally, they represent a significant avoidable cost within the healthcare system. According to CMS, readmissions cost the Medicare program $17.5 billion per year in inpatient spending. To reduce this financial burden, as well as the emotional burden on patients and families, healthcare workers must initiate measures that help to identify patients who are at the most risk for readmissions and develop processes and procedures to prevent these readmissions. Numerous risk factors are associated with hospital readmissions, including specific diseases and conditions, as well as the presence of comorbidities. Most readmissions occur among Medicare patients over the age of 65. Some readmissions are associated with poor quality inpatient care, disease burden, socioeconomic status, the number of previous discharge medications, and ineffective hospital-to-home transitions. Repeat readmissions may also be due to the expected progression of a disease. Hospitals, health plans, CMS, and many consulting firms are all working hard on trying to solve this. But as almost everyone knows, healthcare is hard. Our capstone goal is cost and readmission efficiency. We want to predict patients at risk for readmission, understand what those risk factors are, and design specific interventions to prevent readmissions.
Our dataset is public. It comes from the UC Irvine Machine Learning Repository. It contains 100,000 patient records collected from 130 hospitals in the United States over 10 years, from 1999 to 2008. Each record is an encounter a patient has with a hospital, and because we have patient ID number, we know that there are 70,000 unique patients, which means a lot of people in the set are admitted more than once. To preserve privacy, the data anonymizes or groups some of the continuous attributes into buckets, so we do miss out on a few variables that prior research has suggested would be helpful in understanding drivers of readmission. This includes attributes like sociodemographic factors and location data. At the most basic level, all the people in this dataset have diabetes. However, a giant nuance of our data is that not everyone in our set is admitted to the hospital as a direct result of that condition. Every patient that is admitted to a hospital is given diagnosis codes, which are variables provided in our data. These codes are standardized worldwide. The first code you're given is the primary reason you're admitted to a hospital. The second diagnosis code is the next reason, and so on up to 12 codes. There are thousands of codes, everything from diabetes and heart failure to things like struck by lightning or injury during yoga. In our data, we get the first three codes. 38% of the records are encounters where the patient was admitted with diabetes as the primary reason, which means a lot of diabetic patients in our dataset are admitted primarily for other reasons. This graph shows the frequency of each primary diagnosis code in our set. Interestingly, if a diabetic person is admitted to a hospital for something other than diabetes, there's a high likelihood that they are being admitted for heart failure, pneumonia, or a heart attack, all conditions currently penalized for hospital readmission.
After several iterations of the CRISP cycle, we identified 4 models based on the patient admission history and primary diagnosis. Depicted decision rules identify which models to use depending on aforementioned characteristics. Models A and B address those patients that do not have a history of readmission. These are first-time readmitted patients, while models C and D are built for those patients that already have a history of readmissions. Output of the model shows that the number of readmissions is an important attribute that is used as a feature. It turns out to be the most important predictor for subsequent readmissions, but it can only be used for models C and D, since it is not available for first-time readmitted patients. We also want to separate the models further, depending on whether diabetes is one of the primary reasons for admission, to see how well it affects the performance of our models. 4 machine learning algorithms were run for each of the 4 models. Models A and B show marginal improvement compared to random selection, which is evident from the ROC curve, with average area under the curve between zero point 0.5 to zero point 0.6. Model B, that was used only on patients that had diabetes as one of their primary reasons for admissions, performed better, with 12% recall compared to 8% for Model A. This means that we have an opportunity to prevent one readmission by proactively targeting 7 diabetes patients using various intervention strategies. Model C and D perform much better compared to A and B because we possess more information related to patients' admission history. Models C and D show high areas under the curve in the range of 0.74 to 0.84. Like the first time readmitted scenario, we notice that the models addressing those patients that have diabetes as one of the primary reasons of admissions, namely Model D, performs a little better with a recall rate of 52% compared to 51% recall for Model C. This means we have an opportunity to prevent one readmission by targeting 2 patients with proactive intervention strategies. One of the key predictors for this model was the number of readmissions for a given patient. This implies that the patients who were readmitted before have a much higher risk of being readmitted and require special care. Our models identified several key predictive attributes that can be leveraged as a basis for potential interventions. One such attribute is the number of readmissions for a given patient. Those patients having a high number of prior readmissions are also at a high risk, and thus they require proactive care plans. Telephone follow-ups can substantially reduce the risk of readmission to ensure that patients do not encounter any problems or issues with carrying out their discharge plans. We can carry out home visits with medical volunteers, or we can use technological enablers, such as smartphone applications, to encourage adherence to discharge plans. Based on the discharge code attribute, our models show that when patients are discharged to medical facilities as opposed to their homes, there is a higher likelihood of readmission. To address this finding, we can improve the discharge plans provided by the discharging facility, as well as help enable better communication between the medical facility and care providers. In 2006, CMS penalized over 2,500 hospitals due to excessive readmissions. The total cost in penalties from CMS was $4.7 billion. Team Care has taken a two-step approach to understand the current adoption of predictive modeling and financial outcomes in the healthcare industry. Our goal was to create a better value proposition for healthcare to address this complex problem. First, we looked at benchmarks for existing readmission predictive models. We found that the average accuracy rating of existing models is around 70%. Second, we wanted to develop a model that would improve on this accuracy, which would translate into millions of dollars in savings for the healthcare industry. Based on the Team Care predictive model, we concluded that we could provide at least a 10% improvement on some of the best existing models. This 10% improvement in readmission prediction would translate to over $470 million in savings for hospitals.